Eh, riuscite a sentirmi? Alzate la manina un attimo, chi sente, chi non sente. Occorrono le cuffiette. Ok, io do inizio. Allora, innanzitutto buongiorno e grazie per la partecipazione. Dunque, oggi questa è una seduta che è sponsorizzata dalla Estor e quindi sarà in parte concentrata su strumentazione della Estor, sostanzialmente sull'esta corporea. Quello che mi interessa è parlare soprattutto del perché si fanno o si sono pensate alcune forme di supporto. Quindi oggi parleremo del... I have to speak in English, sorry. Uh, sorry. So today we will speak about the ventilator-induced lung injury, which is a very strange thing. Let me tell you one thing. Now, everybody in intensive care is accustomed, no, to ARDS, respiratory failure, and so on. Now, let me tell you one thing. First, with the mechanical ventilation, we do not cure anybody. We just buy time keeping the patient alive until the antibiotics, the immunity, or whatever takes care of the basic disease. Therefore, all the mechanical ventilation, which has only one goal, to maintain life, that means some level of oxygenation and some level of CO2, the main goal is to provide this goal, this objective, with the less damage possible. Okay? This is any time we speak about an symptomatic therapy, that means when the symptoms may be hypoxia, are such as to make the patient in danger of survival, okay, we have one symptomatic therapy. And the symptomatic therapy has only one objective: buy time without adding injury. And we know since the beginning of the mechanical ventilation that the injury is very, very common. First, when I had your age, I started with mechanical ventilation. And ARDS was our syndrome because the people was dying before. So they start to survive, not much, with intensive care. And of course we had, which possibility we had? We had a ventilator, we were very proud to have a ventilator, we put a tube and started to reach a gas exchange. What is the gas exchange we were reaching? We were reaching the normal CO2, as an example, 40 of CO2. Nobody could think to use 60. And with normal CO2 we have to use in a baby lung, in a small lung of RDS, very high tidal volume because the compliance was very poor. Nobody was caring about the pressures because the devil at that time was the oxygen. So everybody was keeping the oxygen not greater than 60%, and who cares about the pressure? We have patient ventilated with 100 centimeters of water. Which was the result? Explosion of the lung. After 2-3 days, most of the patients had a pneumothorax, pneumomediastinum, pneumoperitoneum, pneumo everywhere. Okay? And so the first recognized was damage of mechanical ventilation was called barotrauma. That means trauma from pressure. Then the first therapeutic approach, because it starts with the membrane lung, was my friend Zeppel, not running the first ECMO study. They had a control and treated. And 90% mortality in both arms. But if you read the study, what was the difference of treatment in the two, but the extracorporeal? The ventilation was exactly the same, but the FiO2 was different. So this study compared two different FiO2, not two different pressure. Then he came out with Dreyfus, which is a French. He's a French say, okay, he reasoned, but when we have when I go diving, as an example, my pressure in the lung is tremendous, okay? And I don't have any barotrauma, of course, because what is important is the difference of pressure. So Dreyfus start to wrap the thorax, and it showed that what was important was not the pressure per se, but was the differential pressure and the strain. That means the expansion of the lung. So remember, what is crucial in terms of possible damage is the expansion of the lung. In this area of volotrauma, so starting to be careful with the stress, before the ARMA study was in 2000, Ickling, which now build airplane in New Zealand, no? Was a very strange man, very intelligent, who spent a few weeks with us in Milan. We were playing with extracorporeal CO2 removal. And Ickling said, well, but why to remove the CO2? Less the PCO2 goes out. And he said, well, it's a good idea. And he went back to New Zealand. After 2 years, he sent a paper to intensive care saying the permissive hypercapnia. And the permissive hypercapnia was not a randomized study, was nothing compared to that, but changed completely the way the people start to think. And the people start to take care about the volumes. So volotrauma, permissive hypercapnia. Then my friend Valenza, Slasky and so on in Toronto, starting with rats, lung of the rats, suspended, no, in the air. They were given different PEEP and different combination of ventilation. And what they found that if you have continuous opening and closing, you have a greater inflammatory reaction. Okay, and this was done in ex vivo, but not in intact animals, and was called atelic trauma or biotrauma. And Ranieri, with Lasky, Suter and so on, they proved that with a more gentle treatment of the lung could succeed in terms of reduction of cytokine and so on. So we had more and more advance versus the more gentle treatment. More recently we say, okay, we know that the volume is bad, the pressure is bad, the respiratory rate is bad, the flow is bad. What else? Well, these are the four fundamental things. If you combine everything, volume and pressure and rate, it comes out with one unique summary variable, which is the power, the mechanical power, which is the energy that you deliver to the system in a unit of time. Okay? And with the mechanical power, of course, if I the 10 times instead of 1, is mechanical power is 10 times greater, and you have a problem. So frequency, volume and pressure are the cornerstone of this. All this has been associated with a progressive trial. And as I told you in 5 minutes, it took about 30 years to arrive, because medicine is very slow and very conservative. Okay, now, basically, what we have in terms of VILI, we have a baby lung, which is the end stage coming from a very different possible disease. I can have pneumonia, I can have a sepsis, I can have a belly, I can have prostatitis, I can have whatever. At the end of the story, I may have lung problem, and the lung, if we have a spread inflammation of the lung, we arrive at what we call a RDS. So the lung is reduced. So our problem is to, in a baby lung, to maintain the life, which is the goal of mechanical ventilation, through decent blood gases, without destroying the hemodynamics, without destroying this and that and that. Okay? This is the problem. So the key point is, does it exist a safe ventilation? In certain cases, I can anticipate. There are patients in which the situation is such as that whatever thing you do to the lung is harmful. So in some patients, which not all, is a fraction of the patient with RDS, simply do not exist a safe ventilation. For this patient, the indication of support may be indicated without So this is the RDS. We have the stress strain. And remember, what is really important is the strain. The pressure, what is important more than the stress, is the delta pressure, the difference between inside and outside, okay? And the strain is how much a given structure is. And very simple. If I have a patient, we normally, now you breathe about 400, 500 milliliters, 15 times, 12 times per minute. And your FRC is between 1.5 and 2.5 liters, depending by the sex, age, dimension, and so on. So the strain is about 1 to 5, 20%. At each breath, we strain normally around this level. In RDS, to have a strain of 1 is quite normal. But we may have also the stress of 2. So what is the strain? What is the level of strain which is dangerous? And for that we have only one approach to understand the rule, which is the experimental. Because if I have a patient, how can I say this may be dangerous? Because the pathological basis of ventilator-induced lung injury are exactly as you find in RDS without VILI. You have inflammation, we have edema, and so on. So clinically we say this ventilation is harmful because we take maybe 2 groups. We assume that all the variables are distributed equally, but as an example, the ARMA trial, the tidal volume. At the tidal volume, we have a little bit greater mortality, and we assume that this excess of mortality is due to the mechanical ventilation. But of course, experimentally, if I take a normal animal and I just use the mechanical ventilation in different way, whatever happens to this animal is linked to the mechanical ventilation I use, which is the only variables. I don't have any other confounding variables. So the best way to study VILI, to me, is to start with intact animal and follow for how long? It doesn't take 1 hour, 2 hours, or 3 hours. You have at least 2 days, at least 48 hours. And you know, this is an example, is the strain. And you read the literature, no? And you see how many times we have rats. And we apply the protective lung ventilation. And you look at the protective lung ventilation, what is? 6 milliliters per kilo. Now, in a rat, the 6 milliliters per kilo is completely different from the 6 milliliters per kilo in man. I give you an example here. To have, so tidal volume per kilo, okay, 10. In the man, you have an alveolar diameter strain of 10. In the rabbit, it's 35. In the rats, is something, so you can have all distribution. So be careful when you look at the literature, no? Because the animals are different. The mechanical characteristics of the lung are different. As an example, this is the difference between man, pig, and rat. And let me give you one simple rule. In a normal man, the transpulmonary pressure at which I double the lung size, that means the strain is equal to 1. Strain is change in volume compared to the resting volume. If I have FRC of 2.5 liters, I have an inhalation of 2.5 liters, my strain is equal to 1. What is the transpulmonary pressure associated? More or less is 12 centimeters of water, the difference between the airway pressure and the pleural pressure. In RDS, the specific elastance, which is this number, is not very different. So in a classical RDS, the baby lung at 12 centimeters of transpulmonary pressure double its size. He has a small size of 500, becomes 1 liter. I have 3 liters, become 6 liters. I have 5 liters, impossible, big man, 2.5 meters, becomes 10 liters, okay? So just to give an idea of what kind of pressure we are talking about, okay? The specific elastance is the measure of the pressure, the transpulmonary pressure, necessary to double the lung size. When you start to double the lung size, you may have to start to have some problem. You know, this is 12. You know, from this was published on a book of applied physiology about 60 years ago. The numbers are the same. We check that. I suggest you to go to the older literature, no? Which is very informative on the basic of the physiology we deal with. Now, I don't go in the distribution of stress and strain. Just to say one thing, that when I put a pressure, the stress, so the distribution of forces is not homogeneous into the lung. One of the most delicate part is, this is the pleura, and here the forces are concentrated. As in this case, the forces, the line of force you see are concentrated. So here you have more stress and more strain. If you go and you take a patient which is on mechanical ventilation, try to look at the CT as an example. Along the pleural contour, you see sometimes little bubbles, a sort of a grain, which are the initial manifestation of ventilator-induced lung injury. We have seen very clearly in the animals. Okay. Here, volumes and pressure. These are stress and strain are the key point to approach rightly the physiology. Unfortunately, most of the ventilators don't give you no pressure, no volumes, and not the transpulmonary pressure, which is the real pressure which is important. But let me give you an example. You should have in your patient to start to have, okay, what is the baby lung? What is the dimension of the lung? For the dimension of the lung, you may look at the compliance, because the compliance are more or less related with the dimension of the lung, okay? Now, you say, okay, this patient has about 700 milliliters or 1 liter. Then I put the tidal volume, and I have to add. You know that at 12 centimeters of transpulmonary pressure, this volume goes up to here, okay? Goes to the, at 24 centimeters of water, so double of the specific elastance, the volume goes here. Let me repeat, volume 1 liter. At 12 becomes 2 liters. At 24 becomes 3 liters. The total lung capacity is about potentially 2 times the FRC, okay? So if you have an estimate of the FRC, you can count, okay, what is the maximum capacity of my lung, okay? And you have, as an example, here, we put the tidal volume, here you don't have a particular problem, okay? But now let's see, I put PEEP. I take a table and say, okay, I need 20 of PEEP. Be careful with PEEP. PEEP is a tremendous risk. No? Above 10, when you are at 15, you are already in very risky regions. 20, I suggest not to use. Because when you put PEEP, you add a 1 volume. Okay? If I measure the compliance starting from here, the compliance is completely different than starting from here, because the lung is already expanded. As an example, in this case, you see at each tidal volume, I start to be closer to the total lung capacity. Let me give you an example. Try to take a deep breath now. Try. Now try to breathe on this. Do that 20 times per minute for 3 days. And you get an RDS. Easily. And this is almost mathematical. This is what we do with the patients, okay? Of course, here we have. I spoke about volume, and I will speak about pressure. But pressure and volume are two faces of the same coins. I can repeat exactly the same reasoning. Instead to put the graph of the volume, I can put the graph of the pressures, which is the peak, which is the plateau, which is the peak, and so on. But I don't have time to do that. Now, which are the dangerous strain? We found, this is the strain, this was done by Proti. These studies were done in Milan at the time, in which we had the fortune to do the study in a city room. So we could have, each time, instead to take a blood gases, no, you press a button and you have a CT. So you follow exactly what's happening. It was very clear that when the strain was greater than 1.5, you start to have a very exponential. And this is the regions of total lung capacity. Okay? So strain is lethal. And now is a series of the same thing. When my inspiratory lung volume exceed the total lung capacity, this is why I recommend you, when you have a patient, try to figure out how much is the volume you start with. How much is the volume which is added by PEEP? If you know the compliance, you can compute. And you sum the volume that you put with the total volume. And you know in which area you are. And of course, smaller is the lung, greater is the possibility to overcome the total lung capacity limits. Okay? Now, tidal volume per lung weight, for the body weight, okay, was an attempt to normalize. But it's quite ridiculous because, as an example, these are patients with mild, moderate, and severe RDS, different colors. This is the ideal body weight, okay? And this is the total gas volume. And you see there is any relationship, because a man of 70 kilo may have a baby lung of 500, 1 liter, 1 liter and a half, 2 liters, under the umbrella of a RDS. So this is why it's so important to have an idea of measuring lung volume. We always measure that with the helium, with a very, very old system, but in the last 30 years, I would have problems to treat a patient without having an idea of volume and the PEEP volume. And this is just an example. This is the reverse side, no? Is the mechanical ventilation. And you see, you have the mythical 30 centimeter of water. Everybody knows that 6 milliliters total volume per kilo, 30 centimeter water plateau. And this is the Vangelum. Now, with 30 airway pressure, you may have a pleural pressure of 24, 20, 15, or 6. That means the transpulmonary pressure is 30 minus the pleural pressure. And depends how elastic is the thorax. And these are real numbers. This is the Spain we have when we put when you use these kind of things. And remember, when you have a big strain and big pressure, you are at risk for the lung structure. But if you have the thorax, which is very, and you increase the pressure, the transpulmonary pressure is lower, but you are at greater risk of hemodynamics. So, and remember, I didn't speak hemodynamics until now, but anytime you touch the knob of the ventilator, you change the hemodynamics. And after 7 years that you are in Germany, and you are playing just with this kind of thing, no? With a big, with the Deutschland pigs, no? Schwein, big also, and we do 48 hours of support and so on, and we have this kind of results that I am more and more convinced that the structure, the lung structure, is very solid. What creates a real VILI is the interaction between and hemodynamics. Because hemodynamics, nobody cares. Because you say, okay, I use pressure. What is the problem? Hemodynamics, the pressure goes down because I'm increasing the airway pressure, 20 ppb, easily. I put 2 liters of water, some cardioactive drug, and the pressure is maintained. But the price that the patient pay for that, or the pigs pay for that, is tremendous. In terms of edema in different organs, more edema into the lung, and so on, is extremely important, the hemodynamics. In spontaneous breathing is the same way. All I said about the mechanical ventilation, you could be transferred to the spontaneous breathing. In terms of mechanics, with the ventilator, my mechanical power is provided by the energy company. No? Now the gas costs too much, but anyway, this is the cost we have. When I'm in spontaneous breathing, instead of the ventilator, I use the respiratory muscles. But if I use the same energy, the effects on the lung structure is exactly the same. And this is what is called patient-induced lung injury. If I had 0 here and minus 20 here, or minus 30 years, the stress and strain are tremendous. The difference are the hemodynamics. In one case, I have an obstacle to the venous return when I have positive pressure. When I have big like this, I have more sucking into the blood. That means even more edema. Because to have edema, you need water and you need blood. No water, no edema, point. Okay. Anyway, spontaneous breathing and mechanical ventilation, the basic principle are exactly the same. So essential monitoring are FRC and stress and strain. And when you know that in these patients, to maintain, let's say, PCO2 60 and PO2 over, because we need, basically, we breathe for the ventilation, to eliminate the CO2. The problem of oxygen is far less than the problem that we have for CO2 clearing. In this condition, anytime you see that the price you have to pay in terms of fluids or in terms of pressure you have to use and the risk of the baby lung are an indication for an extracorporeal support. And a little bit, if I need 20 liters, 15 liters of ventilation to remove 200 milliliters of CO2, if I remove 100 milliliters of CO2 with extracorporeal support, I need 7.5 liters of ventilation. Because the total CO2 to be eliminated is always the same. But I have a large possibility to control, to monitor, and to make the mechanical ventilation less dangerous as possible. I'm over. Okay? Now my colleague, thank you. Mickey.
Just wait, it will be there. So it has been a really great pleasure to hear this story from Professor Gattinoni. And we have heard ARDS. It is not a problem of the high pressures or of the low compliance. It is a problem of the small size of the lung. So as we have heard in the end of the talk by Professor Gattinoni, it would be really nice if we could reduce the CO2 in extracorporeal circulation and thus apply less of the power to the lung to ensure the ventilation. And of course, I would like to follow up now on this talk with some of the practical aspects how we could achieve that. I do like to start with this slide, just to show you the idea that to remove CO2 from the blood directly, this is really nothing new, but Professor Gattinoni has introduced this concept in the 1970s already. And he had stated that actually, technically, it is quite simple to remove CO2 directly from the blood. The development of such technology, of course, it has taken a bit of time so that we can really use it in the clinics and that we are at the point where we are now. By now we have several options to modify the ventilatory management of our patients in the ICU by removing CO2 directly from the blood. But the question that we should ask ourselves, of course, is how can we achieve the best possible results? What blood flow do we choose? What kind of membrane do we choose to remove the CO2? And factors that will influence these decisions, they will be really vital to have a good therapeutic concept that we can use. So it's a good opportunity here to consult the fundamental principles. So in the blood, one of the striking possibilities is that in a very small volume, there is a lot more CO2 contained than this is true for oxygen. If you have the partial pressure on the x-axis, you have the content of the gas on the y-axis, and you see for O2 the curve is much shallower than for CO2. And if we are able, across a membrane, to have gas exchange, it follows that it's much less blood flow is needed to remove CO2 from the blood than to add oxygen. And this is basically the principle that we are building upon to remove CO2. But as I said, we have to choose these parameters very wisely. So what is the optimal flow to remove CO2? It all comes down in the end to weigh the positive effects and the negative effects of an intervention against each other. And in an extracorporeal circuit, the negative effects, they include the transmembrane pressure drop, which causes hemolysis, which causes strain on the blood. It includes, of course, the coagulatory activation that takes place across the surface of the membrane and the tubing. And the positive effect that we have, of course, is the removal of CO2. So we want to balance those two. So on the device side, these properties depend on the sweep gas flow that we have across the membrane, on the blood flow that we apply, and on the membrane surface area. And the blood flow, it will negatively influence the transmembrane pressure. We want to pass more blood in the membrane, we induce more strain on the blood, but of course it's better for coagulatory activation because there is less contact time between the blood and the membrane. And the inverse is true for the membrane surface area, where a larger surface with larger amount of capillaries where the air can pass through and the blood can pass around, will give me less of the transmembrane pressure. So it's really vital to think about these things. And there has been a lot of studies actually done, some basic research, mostly in animals, where this relationship could be shown. So it's very clear, the higher the blood flow, the more CO2 elimination we have, and also the more transmembrane pressure. So this is very simple. If we now introduce the possibility of different membrane surface areas, we see the influence of the membrane surface area. Of course, more CO2 removal with the higher area and less transmembrane pressure with the higher area. And coagulatory activation, this is the third aspect. it plays really a big role in this kind of treatment. It may lead to premature clotting of the system, making it actually less usable. So it is advisable to maintain a high blood flow rate, as high as you can, and titrate the efficiency of the system by using the sweep gas flow. So this is something you can easily achieve. On the other hand, of course, the influence of the device here plays an important role. We see here the data of a study that we made in Zurich in our cohort of Accor patients, and we compared here a CO2 removal system, the prolonged system, in the old version to the left, and a new version with a new configuration of the membrane to the right. And you see that the run times of the membrane system has greatly increased just by switching the materials and optimizing the device. And you may notice here still some of the very short run times they remain, and those are the ones that depend on the patient setting. Mostly those are the patients that are awake instead of mechanically ventilated, where it's much more difficult to maintain the pressures in the extracorporeal system. And in addition to the relationship between the blood flow and the transmembrane pressure gradient, of course, this also depends on the catheter and on the tubing of the system. The pressure gradient, you know very well, is across the catheter is proportionate to the fourth power of the radius, so this makes a huge difference. But if you see, if we are talking about the very low flow that we need for CO2 removal, in this area below 1 liter per minute, we can go to really small catheters, and we could even use the standard 13 French double lumen catheters that you're used to for renal replacement therapy. And this will be enough for CO2 removal. So taking all these technical considerations together, it is apparent that there must be a sweet spot. There must be a perfect set of parameters that allow to implement such a treatment. And such a sweet spot, it probably lies at the upper end of the flow that we can achieve across a double lumen 13 French catheter. It's around 400 to 500 milliliters per minute, that with a large enough surface area will allow us to eliminate a significant amount of CO2. We see in a different study here, this was what was performed with the prolonged device that we have seen the data from Zurich before. It has a surface area of 1.8 square meters, and you see that with 400 milliliters of blood flow, we are able to remove about 150 milliliters of CO2 per minute. So with this theory from the animal data and from the physical considerations, of course, what is the effect of this on the bedside is the really important question. We see again some data from the cohort in Zurich, where we see that with a low flow system that has target of 400 milliliters per minute of blood flow, we are able to reduce the CO2 in the first hour of treatment by about 6 kilopascal. And we're able to maintain this in the steady state thereafter, resulting in a decrease in the pressure that is applied here by the ventilator. So this is a cohort of ARDS patients where Accor was used as a rescue therapy. We will get back to these different concepts. So now we know the theory, we know that clinically the device is applicable. So I think the answer to our initial question, which was, does the blood flow matter in such a treatment? Of course, it does matter. The answer is yes. So low flow Accor, it will balance, I think, the treatment properties, and we are kind of at the sweet spot to implement CO2 removal in the clinical setting. And with this amount of CO2 removal, considering the CO2 production of a human of about 250 milliliters per minute, you see that we are able to remove about 50% of the CO2 production of our patients with this technique. And I've talked about this device. This is just an example. There are multiple devices available, but the Prolong is one device with a really high surface area, which is nice. And also we are provided with real-time monitoring of the actual CO2 removal with a monitor that's included in the device, which is not something that you can achieve by measuring CO2 in the blood gases. Because as you know, or as you have seen, the relationship between the soluble CO2 in the blood and the CO2 content, we cannot really measure in the patient. So it's very nice to have this information available. So of course now the question is, how should we use this technique now that we have it available? We have already, I think, received the best answer in the first talk. We can expand maybe the point of view a little bit and take one step back. And in principle, we can have a more proactive strategy, or we can have a rescue strategy. And if we talk about patients with ARDS, we have heard low lung compliance, but well, it's just the lung as a full organ that has a low compliance, and the problem is the small size. Remember that. We use low tidal volumes, but we also we need to use sedation, because one of the big problems is the J receptor mediated stimulation of respiratory work, which means that the patient will destroy his own lung. And this is something we can only prevent with sedation. So patients will be sedated and mechanically ventilated, but in the ultra-protective approach, we would try to reduce the tidal volumes even below 6 milliliters per kilogram, maybe to 4 milliliters per kilogram. We will get back to some of the data later on. And the other strategy that could be applied would be a rescue strategy, where if with the common goals to keep the tidal volumes below 6 and the pressures below 30, we are not able to ventilate the patient anymore, this would be the time to introduce ECHO. So those are the two approaches. And considering patients with COPD, acutely exacerbated COPD, those two concepts could also be translated. There we have the problem, of course, of the high resistance, but we have the other considerations that we have difficulties of weaning patients that are intubated, and we actually don't want to intubate them. Spontaneous breathing in COPD, of course, is desirable, and it's not a problem. So the proactive strategy there would be to introduce ECHO in the moment that the patient has his respiratory decompensation, and then avoid the intubation altogether. Whereas the rescue strategy, of course, would be to enable a rapid weaning process from the ventilator with ECHO. So those are basically the four concepts that we could be talking about. And in all those four cases, I think it's most important to think about the physiology. I think my predecessor would certainly agree with this statement. So in respiratory failure, we have two things that could go wrong, and one thing is the increase in alveolar arterial barrier, and the other thing is, of course, the decrease in alveolar ventilation. And they are both reasons for respiratory failure. The first more for the hypoxic failure, and the second for the hypercapnic failure. And whenever this happens, our patients would increase his respiratory drive, would increase his work of breathing, and recompensate the blood gases. And only when the patient is not able to compensate for this increased work of breathing anymore, we would have manifestation of hypoxia and hypercapnia. So we would always detect before this happens by looking at the patients where we stand, but not by looking at the blood gases. This would be the point where we would usually then intubate the patient and have positive pressure ventilation, at the risk, as we have heard, to put the stress, of course, that's needed to bridge the respiratory failure on the lungs and induce ventilator-induced lung failure and multi-organ dysfunction. And there, of course, is the extracorporeal removal of the CO2, which is the option to remedy this problem. When we also have the hypoxic failure, we would need to supplement oxygen, and then we would be talking about ECMO. So both of these concepts. Taking one step back, You remember the second part of our clinical scenarios? Before this patient would be intubated that has a hypercapnic respiratory failure, so this could be the COPD patient, we could, with extracorporeal CO2 removal, prevent intubation. So this is basically the physiologic setting that we are in. And for those scenarios, we have pretty good reasoning also in the evidence. I won't go into the details. You know very well the ARDS network study, you know the Amato study. It's just the two faces of the medal that both need to be considered, because if you consider the one, the volume, and you do not consider the other, the pressure, it will also damage, of course, the lung of your patient. So you do need to consider both. And it has taken us maybe 20 years to figure this out in between these two studies, but the physiologists have told us this before the Amato study was published in 2018. And we have seen in the cohort in Zurich, I've shown you this slide before, that this works. The rescue approach in ARDS is clinically feasible. And the other scenario would be the ultra-protective scenario in the ARDS. Here is just a visualization of what Luciano Gattinoni has told us before. In the case here, where a large part of the lung is non-aerated and a small part of the lung is only participating in the ventilation, it would be logical to have a lower target for tidal volumes than in this scenario here. And this is the ultra-protective ventilation approach, where we, from the start, aim for a lower tidal volume. And this concept, it has been explored in science. This is the Supernova trial, which was funded by the ESICM. It was conducted in 23 centers. And it was quite heterogeneous, because different devices for extracorporeal CO2 removal were used in this study, with also different flow rates. So there were low flow devices, there were higher flow devices. But nonetheless, it was shown that a reduction in the tidal volume of 6 to 4 milliliters per kilogram by introducing extracorporeal CO2 removal was feasible in the clinical setting. And this is the conclusion of this study, because what is of course missing here is the effect of this on the outcome. That was not the aim of the Supernova trial. For this we have the REST trial that was just published in August of last year. It was conducted in 51 centers. So as you see, this is a treatment where you need a lot of numbers of centers to get adequate patient numbers to study this. We had 412 patients in this study. But unfortunately, this study was terminated at only 44% of the patient inclusions that were anticipated for adequate statistical power. So the negative result in terms of the 90-day survival that this study showed is now really difficult to interpret. It does once more show, I think, that it's really difficult to conduct large studies in a critical care setting. Now, regarding the avoidance of intubation in COPD patients, there are two studies I would briefly mention, but they are retrospective studies. They show a reduction of respiratory rate, and they show a reduction in the need for intubation in the COPD patients when ECHOR is directly initiated when patients are treated with non-invasive ventilation. These studies, I think they are, being retrospective studies, we need to consider them with caution regarding the treatment decisions, but they show ECHOR is a treatment that's well tolerated in awake patients, and this is something that's really important to know. So we can conclude the current evidence, it's not really easy to integrate regarding this kind of treatment. And I think that one of the main challenges that remains is the selection of the patients, of the correct patients that will benefit the most from such a treatment. And also, of course, the selection of the kind of strategy that we want to implement. And for this reason, 2 years ago, there was a consensus conference where some of recommendations were published for the use of ECHOR. And they are actually covering those 4 scenarios that we have just discussed. In ARDS patients, a target of 9 kilopascal or 60 millimeters of mercury of CO2 is considered a good point to start ECHOR when you also reach in mechanical ventilation these protective goals under progress of the disease. And the respirator settings, of course, they differ for the recommendations for ultra-protective ventilation, where you would aim for smaller tidal volumes. And the same as in the REST trial, it is recommended that in such a case, the ECHOR treatment will be applied for 48 hours. And thereafter, as long as the driving pressure and also the oxygenation have partially recovered, you can attempt to wean the ECHOR system over a period of 12 hours by reducing the sweet gas flow. In patients with acutely exacerbated COPD, again, we have a very different clinical scenario. So our indication to start the treatment will depend much more on the clinics. So you see here the clinical signs of respiratory failure for patients that are awake and spontaneously breathing. And patients that are already on the ventilator, you could consider extracorporeal CO2 removal after a weaning failure of 72 hours by standard weaning procedures. And weaning should be considered once the intubated patients would be successfully extubated, of course, or the awake and spontaneously breathing patients would not depend on non-invasive ventilation anymore. Of course, you can then again have your clinical impression, and the patient should be recompensated for his work of breathing. So in addition to patient selection based on the physiology, the most important goal would be to select your patients that benefit from this bridging strategy. We need to buy time for survival and to treat the underlying disease so that the patient can recover. But we need to select those patients that are able to recover for such a treatment. And this, I think, is next to the physiology really, really important. So in the Zurich cohort, we have looked at the outcomes of our patients. And keep in mind that in a few of those studies that I've shown you, actually the mortality was not so low, and that was probably because of patient selection. So a relatively high proportion of patients did not reach a favorable outcome, even if ECHOR by itself was successful in removing the CO2 and enabling the protective ventilation because the patients were just not able to recover. Of course, the ARDS patients, they belong to probably the sickest subpopulations that you could find in your ICU. So this is, of course, not a surprise. And our data basically confirms the ARDS, the lung fibrosis, of course, and also the bronchiolitis obliterans patients. Those are the patients that have the failure of lung transplant grafts, which of course is not a good thing. Those are the main contributors to mortality. And in all the other patients, the outcome was pretty good in the long term, including the COPD patients. And additionally, in most patients with unfavorable long-term outcome, treatment was actually withdrawn on ECHOR, which is what you see here. This means the withdrawal of life-sustaining treatment on ECHOR, which was leading to the bad ICU outcome. And once they had recovered from the ECHOR therapy, the long-term outcome was usually good. Also, if you consider the awake group versus the mechanically ventilated groups, in the awake group, the outcome was generally favorable. And the same is true for the bridge to transplant approach versus the bridge to recovery approach, where you see here, which is kind of obvious. So The question, of course, it remains how to extend the selection criteria of our patient population for ECHO treatment, considering this long-term outcome that we want to ensure. And there are already validated systems to assess long-term outcome before ECMO treatment is initiated. For example, the PRESERVE score. So we have applied this PRESERVE score to this cohort of ECHO patients, and we have seen that it performs about equally well in the ECHO population as in the ECMO population. So this might be a good way to select, in the case of ARDS, suitable candidates for ECHO therapy. This could provide some guidance for us. So with this, I thank you very much for your attention. Open to questions.
We have 2 minutes. Yeah? If there is any question, some urgent question? No? Okay, I think the bar is open. I hope. Okay, thank you for the attention again. Okay.
Thank you very much.
Okay. Good job. Okay.
Well, it was just the practical aspects.
No, well done. Huh?